Welcome to the Philadelphia Regional Center for Children's Mental Health seminar. And today we have a speaker, Stephanie Mayne. Stephanie Mayne is assistant professor of pediatrics and epidemiology at the Children's Hospital of Philadelphia and the University of Pennsylvania. Her research focuses on the impact of neighborhood environment characteristics on child health outcomes, including sleep, obesity, mental health, and primary care utilization. She is the Associate Director of Clinical Epidemiology at CHOP's Clinical Futures and a faculty member of CHOP's Policy Lab. She's also a member of the Possibilities Project, an innovation initiative at CHOP that reimagines pediatric care delivery to improve outcomes and meet children's future health needs. Stephanie, it's yours.
All right, thank you so much, Iman, for that introduction. I'm really excited to be here to talk about a couple different projects. Let me get back to my slides. Okay, so today I'm going to talk about two projects. The first is a PRCCEH-funded pilot study looking at the relationship of extreme temperatures and missed pediatric preventive visits. And then I'm going to share some other work from our team that looks at the relationship between neighborhood opportunity and key pediatric primary care outcomes. So before I get into those studies, I want to talk a little bit about the setting in which all this research is conducted. So all the research in this talk takes place within the Pediatric Research Consortium, or PERC, which is the Children's Hospital of Philadelphia's pediatric primary care practice-based research network. So PERC is a network of 31 different pediatric primary care practices. They're shown with the purple stars on this map here. So these are practices that are in urban, suburban, and semi-rural parts of southeastern Pennsylvania and New Jersey. 6 of them are in the city of Philadelphia, and then the rest are sort of scattered around the surrounding area. And these primary care practices care for approximately 300,000 patients per year. PERC was established in 2002 with funding from the Agency for Healthcare Research and Quality. And it has facilitated hundreds of clinical research projects since then. And all of the practices have a shared electronic health record system, which really facilitates the kind of large-scale epidemiologic investigations that I am going to talk about today. I'd also like to talk a little bit about our team. So I consider myself very lucky as an epidemiologist to be able to partner with pediatrician researchers and other types of experts on this work. So our team is called the Possibilities Project, or TPP. And TPP is CHOP's primary care innovation incubator. It's a team that works on a lot of different projects to try to reimagine pediatric primary care delivery in order to improve outcomes and better meet the needs of children and families. So this is a group that includes primary care clinicians, quality improvement and data analytics experts, health equity experts, me as an epidemiologist, health informaticists, and more. So it's a team that does a lot of work, including research, QI, and implementation. It's a large team, but I wanted to highlight the colleagues who were most involved in the work that I'm going to be presenting today. So that's a little bit about us and where our work takes place. So now moving into the specific studies, the first one is investigating extreme temperatures and missed pediatric preventive visits. So to give a little background on the topic, as I'm sure the audience of this webinar is aware, global temperatures have risen substantially in recent years, exceeding 1.5 degrees Celsius above pre-industrial averages in 2024. And temperatures are expected to continue to rise even more throughout the rest of the 21st century. As climate change drives more extreme temperatures and weather patterns around the world, the potential impacts on human health are an area of large concern. And in the context of child health, so the area that our team focuses on, extreme temperatures can pose direct risks to child health through heat-related illnesses, learning difficulties, stress, poor sleep, and more. And they also have the potential to impact healthcare utilization. A growing body of evidence has linked extreme daily temperatures in the warm months of the year with greater utilization of emergency and inpatient care among children, with higher rates of ED visits and hospitalizations associated with hotter temperatures in multiple studies. For example, a large study that used national insurance claim data found that extreme heat, so heat at or above the 95th percentile of the local temperature distribution compared to the median, was associated with a 30% higher rate of ED visits for heat-related conditions, and also higher rates of ED visits for other types of conditions as well. And several analyses of emergency department admissions data from New York City has found excess risk of ED visits as daily maximum temperatures increased, especially among very young children. But little is known about the impacts of temperature on preventive healthcare utilization among children. I got interested in this topic after reading a study that was published in 2024 in the American Journal of Preventive Medicine by researchers at Drexel University. This study was a time series analysis of adult patients in 13 large university primary care practices in Philadelphia. And the research team investigated associations of daily temperatures with the daily rate of missed preventive visits, so either a no-show or a canceled visit. And in this study, they found that the rate of missed visits increased fairly linearly above about 89 degrees Fahrenheit, and also increased at temperatures below 39 degrees, increasing nearly a percentage point per degree Fahrenheit change at the extremes of that distribution. So I thought this was really interesting, and it led me to dig into the literature to see what was known about the relationship of temperature and pediatric preventive care. And I found very little, which helped to motivate applying for the pilot study and then carrying out the analysis that I'm about to describe. But to just step back for a minute and think about why missed pediatric preventive care is such an important outcome to think about. Pediatric primary care is essential for ensuring that children receive recommended preventive care like vaccines and developmental screenings. It's also really important for the management of chronic conditions like asthma and ADHD, and really helping children to establish healthy life trajectories that will carry them throughout the rest of their lives. High rates of no-shows, so scheduled but unattended primary care visits, can adversely impact child health by delaying the receipt of this needed preventive care. They've also found to increase the risk of hospitalizations and negatively impact primary care practices resource utilization as well. Missed preventive visits have multiple causes: transportation issues, scheduling conflicts, maybe just forgetting. And the pediatric context is complicated by the reliance on caregivers for getting children to visits and also needing to work around school schedules. Higher rates of missed primary care visits have been documented among children with public insurance, with food insecurity, and other types of unmet social needs, indicating that socioeconomic circumstances are an important contributing factor. But little is known about whether temperature is related to missed pediatric preventive care. So that brings me to the purpose of our study. Our objective was to determine the association of extreme temperatures with the rate of missed preventive visits in our large pediatric primary care network over a 15-year period. And secondarily, we were interested in examining whether the association between temperature and missed visits, if present, was moderated by age, insurance payer, and neighborhood socioeconomic status. We hypothesized that the rate of missed visits would be higher on days with extreme temperatures, both cold and warm. And we also hypothesized that this relationship would be stronger among children less than 2 years of age, with public insurance, and who resided in lower SES neighborhoods. We hypothesized that younger children, since they might be particularly vulnerable to the adverse health impacts of extreme temperatures, that caregivers might be more likely to reschedule visits for very young children on days that were really hot or really cold. And we also hypothesized that families with lower income, which were proxying with insurance payer, or who are from lower resource communities, could be more strongly impacted due to potentially lower levels of vehicle ownership or greater reliance on public transportation. Our study was an observational time series analysis using electronic health record data. And as I mentioned before, our setting is CHOP's primary care network. The number of practices in the network has shifted a little bit over this 15-year period, but 32 practices contributed data to this analysis. And our study population included all scheduled in-person preventive visits among patients less than 19 years old between January 1st, 2009 and December 31st, 2023. So we were focusing on preventive visits, so well child care specifically. For each day of our study period, we identified the total number of scheduled preventive visits at each primary care practice in the network, and then the number of those visits that was missed. So the level of our time series analysis was the practice day level. And we did this because the patterns of missed visits vary between different primary care practices, and also because practice is kind of the unit at which any interventions or policy changes informed by these results would be implemented. So we defined a missed visit as a visit that was either coded as a no-show, so attended, scheduled but not attended, or that was canceled on the day of the visit. The reason that particular visits were missed is not documented consistently throughout the network, so we weren't able to confirm the reason that parents gave for the cancellations. So for this reason, we didn't examine visits that were canceled or rescheduled ahead of the visit date, because we're already making some assumptions trying to attribute missed visits to temperature based on these population level patterns. And we didn't feel that we could really identify visits that were canceled ahead of time due to weather forecasts, for example. So we focused just on same-day cancellations and no-shows. Our exposure of interest was the daily maximum temperature, which I'm also going to refer to as Tmax. So following the example of that study, the Drexel study among Philadelphia adults, we examined daily maximum temperatures using data from NOAA's Global Historical Climate Network dataset, or GHCND. Which contains daily data on temperature and precipitation from monitoring stations around the United States. And because our time series analysis was conducted at the practice day level, we assigned daily temperature values to each practice on each day of our follow-up period by averaging the values for monitoring stations in each practice's county. Over our study period, Tmax ranged from 13.1 degrees to 104.5 degrees Fahrenheit, with a median of 67.3 degrees. To estimate the associations of daily temperatures with daily rates of missed preventive visits, we used generalized linear quasi-Poisson models. The dependent variable was the daily count of missed visits at each practice, and then we used as an offset the log of the daily number of scheduled preventive visits at each practice. We modeled Tmax, our exposure of interest, as a natural cubic spline term with 5 degrees of freedom to account for nonlinearities in the relationship of missed temperature with missed preventive visits. And we chose the optimal number of knots by comparing QAIC values to determine the best fit to the data. In our primary analysis, we focused on same-day temperatures. We didn't examine temperature lags, which is an approach that's often used in analyses of temperature and health outcomes. But we really hypothesized that for the outcome of a missed preventive visit, that the temperature on the day of the visit was going to be the most causally relevant to no-shows and same-day cancellations. We included month and year fixed effects to account for secular trends and seasonality in the missed visit patterns. And we also included a fixed effect for primary care practice to account for underlying differences between practices that can contribute to missed visits. And we adjusted for the following day level covariates: day of the week, whether the day was a holiday, precipitation, so rainfall, and also snowfall. To determine whether the association of daily maximum temperature and rate of missed visits varied by age and socioeconomic status, we also conducted models that were stratified by population subgroups. So among ages less than 2, 2 to 5, 6 to 12, and 13 to 18. And then among children who were publicly insured, so Medicaid or CHIP insurance, or commercially insured, or other insurance. And then as a measure of neighborhood socioeconomic status, we use the Child Opportunity Index, or the COI. This is something I'm going to talk about a bit later in the talk, but for now, the COI is a multidimensional indicator of neighborhood environments, a bunch of different indicators that are highly relevant to child health. And it has 3 different domains: education, health and environment, and social and economic indicators. So for this analysis, we use that social and economic domain as an indicator of neighborhood SES. And the score is categorized according to quintiles into groupings of very low, low, moderate, high, and very high socioeconomic opportunity. And we use the Cochrane's Q statistic to test for heterogeneity between these different subgroups in the relationship of extreme temperatures with missed preventive visits. Our study population included over 500,000 unique patients who were approximately evenly split by sex, approximately 8% Hispanic or Latino, 30% non-Hispanic Black, 44% non-Hispanic White, 18% other or multiple racial or ethnic identities. About 57% were commercially insured and 36% publicly insured, and we had a distribution across different neighborhood SES levels, but with the highest percentage of children in the very low and the very high SES categories. Among those 500,000 children, there were a bit over 4 million scheduled preventive visits during our study period. And of those, 13% of visits were missed, so either a no-show or a same-day cancellation. We compared the baseline percentage of no-shows across different population subcategories, and we found the highest percentage of missed visits among patients with non-Hispanic Black race or ethnicity, other insurance type, and very low SES neighborhood residents. This slide is showing the main results, so the results in our overall model looking at the full population. The curve is showing the rate ratio of missed preventive visits at each point along the temperature distribution from 13 to 104 degrees relative to the median temperature of 67.3. So we can see from looking at the curve that at above about 80 degrees or below about 40 degrees, the rate of missed visits increases relative to the median as the temperature becomes more extreme. And the table is showing contrast at specific temperatures throughout that distribution. For example, at 36.5 degrees, which was the 5th percentile in the overall temperature distribution, the rate of missed visits was 5% higher than at the median temperature. And at 91 degrees, which is the 95th percentile of the temperature distribution, the rate of missed visits was 4% higher than at the median. So going back, we see sort of a linear relationship between temperature and missed visits at the tails of the distribution. This is something that was seen in that prior Drexel study as well. And emulating that study, we also conducted models where we modeled temperature as a piecewise linear term to estimate how much the rate of missed visits increased above or below a threshold. So since those linear relationships were seen at about above the 90th percentile and below the 10th percentile of the temperature distribution, we modeled these using piecewise linear terms to estimate the association per 1 degree Fahrenheit difference. And for this analysis, we stratified into cold and warm months. This is an approach that's often used in studies of temperature and health to better facilitate interpretation of results. So in the cold months of the year, so November through April, we found that each degree Fahrenheit decrease in temperature below 41.5 degrees was associated with a 1.2% increase in the rate of missed visits. And in the warm months, so May through October, each 1 degree Fahrenheit increase above 88 degrees was associated with a 0.5% increase in the rate of missed visits. Now for the stratified models, I'm going to show tables that show those piecewise linear models that are, again, the increase in the rate per degree Fahrenheit change in temperature, and then also the curves showing the nonlinear patterns overall. When we stratified by age, we found stronger associations among children less than 2 years old in cold months. So for children under 2, the rate of missed preventive visits increased by 2% for each degree Fahrenheit decrease below 41.5 degrees, compared to a 1% change for the older children. And there were no differences seen in the warm months of the year. When we looked at our strata-specific graphs, we can see there's a steeper incline among the less than 2 group, but overall, the general pattern is pretty similar across age groups. When we stratified by insurance payer, which we were using again as a proxy for individual SES, we found a stronger association in commercially insured children in the cold months. So again, each degree Fahrenheit decrease in daily temperature below 41.5 degrees was associated with a 2% higher rate of missed visits among the commercially insured kids, compared to 1% or 0% among the other groups. And there was less of a difference seen by payer in the warm months of the year. And again, if we look at the curves, we see a more extreme tail of the curve in the cold months among the commercially insured children. Finally, when we stratified by neighborhood socioeconomic status, we found a stronger association among children from high SES neighborhoods in cold months. Specifically, children living in high and very high SES neighborhoods had a rate ratio of 1.02 compared to 1.01 in the other categories. In the warm months, we found an association that was stronger among children in very low and high SES neighborhoods with a 1% higher rate per degree temperature increase above 88 degrees. I mean, we can see, looking at the curves again, more extreme cold weather peak in the higher SES groups and a little bit of a difference in the warm months. As a secondary analysis, we also looked at precipitation and snowfall's relationship with missed visits. So because rainfall was skewed, we examined the association for rainfall levels falling between the 75th and 90th percentile and then above the 90th percentile versus less than 75th percentile of rainfall. And we found that on days where rain was in the 75th to 90th percentile, the rate of missed visits was 4% higher. And then in days with rain above the 90th percentile, the rate of missed visits was 8% higher. And on days that had snowfall, the rate of missed visits was 33% higher compared to days without snowfall. So overall, we found that extreme temperatures were associated with higher rates of missed pediatric preventive visits, with somewhat stronger associations seen in colder months compared to warm months, and some evidence of differences by age and socioeconomic status among the cold months in particular. These SES patterns were opposite of what we had originally hypothesized, with commercially insured children and those living in higher opportunity neighborhoods having stronger associations of temperature with missed visits as temperature decreased. There's several possible explanations for this. First, the baseline rate of missed visits was much higher to begin with among children who were non-commercially insured or who were from lower SES neighborhoods. So it could be that this is driven by factors that are not sensitive to temperature, whereas associations perhaps were more apparent among the subgroups that had lower rates of missed visits overall. Or it might be that families from higher SES settings could have more flexibility to reschedule appointments in the event of extreme temperatures or extreme weather, while families with more constrained resources might need to attend visits regardless of the temperature due to issues like limited appointment availability or difficulties in getting time off of work. Future qualitative work would be really needed to understand what is lying behind these differences, which was beyond the scope of this pilot study. So overall, these findings suggest that hospital systems and clinics may anticipate temperature-related impacts on healthcare in the future and consider potential mitigating solutions. Telehealth appointments have been found to reduce the likelihood of no-shows at pediatric primary care appointments overall, but future work is needed to understand the effect of converting missed visits to telehealth in the context of extreme temperatures and whether that's an approach that could be leveraged to mitigate some of these impacts. Some additional approaches that our team has kind of talked about in brainstorming and thinking about these results could be things like facilitating transportation for patients with transportation challenges on these extreme temperature days through something like partnering with rideshare vendors. Practices could also think about implementing weather monitoring systems to trigger proactive outreach to patients with scheduled visits when extreme temperatures are forecasted, and enabling flexible rescheduling. Flexible rescheduling policies too, like relaxed same-day cancellation penalties during extreme weather events, or extending appointment availability in the aftermath of extreme weather could help patients maintain access to necessary preventive care. Some limitations to this study. So I think a strength is that it was a large and diverse study sample, including children in urban and non-urban areas, but generalizability is limited given that it all took place within our single geographic region. Other areas with different climates may have different patterns. Second, because this was an aggregated time series analysis, we aggregated the missed visits and the temperature values to the primary care practice level. So the temperature exposures are not reflecting fine-grained differences in temperatures between neighborhoods within larger cities or counties. So it's not going to reflect differences like the urban heat island effect that could potentially make bigger differences from place to place. I think future work using more fine-grained environmental exposures and looking at some more detailed patient-level outcomes will be an important area for future work. Because we used electronic health record data, we lacked information on various individual level characteristics like vehicle access that likely play a role in whether or not somebody misses a visit. And finally, because we were not able to reliably determine the reason for each missed visit, since that wasn't really documented consistently in the electronic health record, we didn't examine other types of visits like those that were canceled or rescheduled ahead of the visit date. So we really focused on those same-day associations. So that's the first study. Now I'm going to switch gears a little bit and talk about some of our work using the Child Opportunity Index and thinking about its potential importance and use in the pediatric primary care setting. As I mentioned before, the Child Opportunity Index, or the COI, is a multidimensional, publicly available surveillance tool that incorporates many different aspects of neighborhoods specifically hypothesized to impact child health. So it incorporates the domains of education, health and the environment, and social and economic status. And it includes a number of different indicators that map on those domains. The newest version, which is the COI 3.0, has 44 different indicators across these domains. And each indicator is weighted and combined into a summary score for each domain and then an overall neighborhood opportunity level. In these analyses, we use the older version, the COI 2.0, because the new one was released just recently. The COI 2.0 had 29 different indicators, which are shown on this slide to give you an idea, if you're not familiar with the index, of the kind of things that are in it. So, for example, in the education domain, there's information like the number of early childhood education centers within a census tract, various measures of school proficiency, graduation rates, etc. Health and environment incorporates factors like access to healthy food, access to green space, walkability, various types of environmental toxicants. It also includes extreme heat exposure, which is why we focused on the social and economic domain as our neighborhood indicator in the prior analysis rather than looking at the overall score. And then the social and economic domain includes a number of different census characteristics like employment, poverty rate, etc. The COI is available at the census tract level throughout the United States. So COI scores are used to rank each tract within the United States to create a nationally normed score that ranges from 1 to 100. So a lower score indicates lower neighborhood opportunity, a higher score indicates higher neighborhood opportunity. And these scores are typically classified into quintiles to create categories of very low, low, moderate, high, and very high. So a very high opportunity census tract would be one that's in the highest 20th percentile nationwide of neighborhood, according to neighborhood opportunity. So here's a map showing the COI levels in the areas of Pennsylvania and New Jersey that are covered by our care network. The light blue tracts are those with very low COI, and the dark blue tracts are those with very high COI. So our team was interested in using the COI as a measure both for research and to try to better understand the equity impacts of our innovation work. But first, we wanted to understand if neighborhood opportunity was even related to primary care outcomes, and to try to get a sense of whether it was capturing anything beyond the impacts of racism and individual SES that we already try to proxy when we look at differences in outcomes by race and ethnicity and by insurance payer. So we set out to conduct two different analyses at around the same time. First, examining associations of the COI with a set of widely used metrics of pediatric primary care adherence and patient and family wellness. And then second, to look at associations with adolescent health vulnerabilities, since adolescent health is a major area of emphasis, both for CHOP's primary care network and for our Possibilities Project team. So the first analysis, which I co-led with Jan Ramachandran, a clinical research study lead on our team, examined the association between the COI and 7 health metrics that are commonly captured in pediatric primary care, which I'll describe momentarily. This was a retrospective cross-sectional observational study using EHR data from our network. And for this analysis, we included all children aged 0 to 19 years old who were active in our care network between November of 2020 and November of 2022. Being active was defined as having a primary care visit within the past 2 years. So this was really a broad population level look at our network overall by COI. Our exposure of interest was the Child Opportunity Index, categorized by quintiles into those categories ranging from very low to very high. This was linked to patients at the census tract level based on their geocoded home addresses. For covariates, we extracted information on age, sex, race, ethnicity, and insurance payer from the EHR. And as outcomes, we selected 7 metrics that we thought would give us a good sense of the potential impact of the COI on primary care broadly. We included the HEDIS metrics for being up to date on well child visits and also being up to date on immunizations as measures of primary care adherence. So basically, are children getting the recommended primary care? And then as measures of patient and family well-being, we included obesity as a measure of physical well-being, and then adolescent and maternal mental health screening outcomes as measures of psychological well-being and family well-being. Adolescents in our network are routinely screened with a PHQ-9M for depressive symptoms and suicide risk, and mothers of infants are screened using the Edinburgh Postnatal Depression Scale for maternal depression and suicide risk. So we're looking at sort of broad metrics that are captured routinely in our network. Our cohort included 338,277 children, of whom about 62% were commercially insured. 24% of children lived in very low COI neighborhoods and 38% in very high COI neighborhoods. And we found, consistent with other studies and consistent with what we know about the impacts of structural racism, that the distribution of neighborhood COI varied by race, ethnicity, and payer type, with non-Hispanic Black patients and publicly insured patients being more likely to live in neighborhoods with low COI compared to patients of different other sociodemographic groupings. So first, we plotted the percent of patients in each neighborhood COI category who were positive for each of these outcomes to get a sense of sort of the absolute differences in these primary care outcomes by neighborhood opportunity. And we found linear patterns by neighborhood opportunity. So if we look at the first plot, this is looking at the percentage of children who are up to date on their preventive visits. Among children in very low opportunity neighborhoods, about 62% were up to date on their preventive visits, which increased to about 75% among kids in very high opportunity neighborhoods. And the pattern was even more extreme for being up to date on immunizations by age 2. That's the HEDIS metric we were looking at here. So 52% of children in very low COI neighborhoods were up to date on immunizations, which increased all the way up to 83% among children in very high opportunity neighborhoods. When we looked at obesity, 26% of children in very low COI neighborhoods had obesity compared to only 10% of kids in the very high opportunity neighborhoods. Patterns were similar across the different adolescent and maternal mental health outcomes. So again, we looked at depression and suicide risk. And again, we see this dose response where there were a lower percentage of teens and mothers screening positive for mental health concerns with increasing levels of neighborhood opportunity. We then conducted multivariable mixed effects logistic modeling that accounted for clustering of patients by census tract to estimate associations of COI category with primary care outcomes. So this is showing just the most extreme contrast of the very high compared to very low COI neighborhoods. We found that the odds of being up to date on preventive visits were 40% higher for children in very high compared to children in very low COI neighborhoods. The odds of being up to date on vaccinations were 80% higher among children in very high compared to very low neighborhoods, COI neighborhoods, and the odds of obesity were 40% lower among children in the very high opportunity neighborhoods. And associations were similar across the different mental health outcomes, with teens and mothers in very high opportunity neighborhoods having 20 to 30% lower odds of screening positive compared to those in the very low opportunity neighborhoods. So this analysis proved to us that neighborhood opportunity was strongly associated with key primary care outcomes related to both primary care adherence and child and family well-being. These results were not terribly surprising given what we know about the impacts of SES and environments on children, but the strength and consistency of these findings really drove home that neighborhood context is something important to think about when we're thinking about primary care. It's important to these outcomes that primary care providers care about and think about and see day to day in the office. And because primary care providers often develop long-term relationships with families and really see the impacts of neighborhood environments over time, this is an important population to think about in terms of the neighborhood environment. Findings underscore the potential value for pediatric health systems in using data on neighborhood opportunity to better understand structural barriers to preventive care access in low COI communities. They can also identify areas of populations that need additional support. Our Possibilities Project team is now typically using COI as one of the axes along which we evaluate the equity impacts of our QI efforts and interventions. Health systems can also use the COI as empirical data to advocate for neighborhood investments and interventions and to develop partnerships with community groups to promote child well-being. I know this is a metric that's used frequently by others, for example, the Center for Health Equity at CHOP. So as we were doing this analysis, we were also interested in understanding the relationship between the COI and adolescent health. So adolescent health is a major area of emphasis for CHOP primary care and for our Possibilities Project team. This is an analysis that I led with Gabby DiFiore, a former study lead with our team who's now a quality improvement advisor at CHOP. This project was built on the implementation in CHOP's care network of a new screening tool called the Adolescent Health Questionnaire that was designed by the Possibilities Project to better standardize screening in primary care for different adolescent health outcomes. So we wanted to characterize the prevalence of different health vulnerabilities among teens in our primary care network and examine differences in how these different health vulnerabilities co-occurred according to age and child opportunity index level. The setting and design are the same in this study as they were for the prior study, but this time we focused in on 13 to 18-year-old adolescents who had been seen for preventive care in the CHOP Care Network between September of 2021 and September of 2022. This was the earliest one-year period in which the Adolescent Health Questionnaire had been fully implemented in our network. So most of the outcomes in this analysis come from the Adolescent Health Questionnaire, or AHQ. Again, this is a screener that was developed by the Possibilities Project to better support pediatric primary care providers in discussing adolescent strengths, identity, and behaviors linked to health risks during preventive visits. And this was developed to overcome some barriers to adolescent care, like time constraints, adolescent confidentiality concerns, and limited comfort or self-efficacy among pediatricians in addressing some of these potentially sensitive topics. So the AHQ is a confidential survey that adolescents complete on a tablet upon checking in to a well teen visit in the CHOP Primary Care Network. And it assesses 8 different domains of adolescent well-being, which include personal strengths, nutrition and physical activity, relationships with family and friends, school, exposure to violence, weapons, violence, or safety, tobacco use, alcohol and substance use, and then adolescent development and sexual health. Items were drawn from validated questionnaires like the CRAFT and the YRBSS whenever possible. And this screener was implemented sort of in stages between 2020 and 2022. For this analysis, we were especially interested in looking at outcomes that really kind of peak in adolescence or are particularly relevant to adolescent populations and that have evidence-based interventions for teens who screen positive. So based on that criteria, we decided to focus on 5 different health vulnerabilities: tobacco use, substance use, which included alcohol and marijuana, condomless intercourse, firearm access, those all came from the AHQ, and then depressive symptoms from the PHQ-9, which is administered at the same time as the AHQ at child visits for adolescents in the network. Here's some more detailed definitions of each of these vulnerabilities. So tobacco use included vaping and other tobacco products. Substance use was drinking alcohol or using any form of marijuana. Firearm access included having a firearm in the home or reporting being able to access a firearm within a day. Condomless intercourse was reporting not using a condom at the teen's last sexual encounter. And then depressive symptoms was a positive screen for either depression and or suicidality on the PHQ-9M. This study cohort included over 40,000 teens, about 53% non-Hispanic white, 71% commercially insured. And when we compare this population to our overall population in the last study, we see a higher percentage of teens who were commercially insured and who were in the very high COI category. I think this likely reflects known racial and economic disparities in adolescent preventive care rates. So first, we were interested in just examining the prevalence of these different vulnerabilities and see whether they differed by age. So we compared the prevalence in adolescents aged 13 to 15 and 16 to 18. And these are all self-reported, so I think there's likely some underreporting due to social desirability bias. But overall, we found 4% of teens reported tobacco use, 9% reported alcohol or marijuana use, 13% reported firearm access, 3% reported condomless intercourse, and 12% reported depressive symptoms. And most of the outcomes were more common among older teens, which are the pink bars, compared to younger teens, which are the blue bars. But firearm access was reported by 13% of teens in both age groups. We then looked at the prevalence of these different health vulnerabilities by neighborhood opportunity. And we found that the reported prevalence of tobacco use, condomless intercourse, and depressive symptoms all decreased as child opportunity index score increased. So we found lower prevalence among teens from higher COI neighborhoods. With substance use, we separated out alcohol and marijuana use, and we saw that the patterns actually went in different directions. Alcohol use was more common among teens in higher COI neighborhoods, while marijuana use was more common among teens in lower COI neighborhoods. And firearm access was most commonly reported among teens in moderate and high opportunity neighborhoods. Next, we were interested in looking at the number of health vulnerabilities being reported by individual teens. And we found that overall, 30% of teens reported at least one vulnerability, 8% reported at least two, and 3% of teens reported at least three of the 5 vulnerabilities. We found that reporting any number of vulnerabilities was more common among older compared to younger teens, and that 13% of 16 to 18-year-olds reported at least 2 health vulnerabilities. When we looked at the percentage of adolescents reporting more than one health vulnerability by COI category, we found a higher percentage of teens in low COI neighborhoods reporting multiple vulnerabilities. So if we look at that green bar, which is the percent of teens reporting at least 2, we found 11% of teens in very low COI neighborhoods reported at least 2 vulnerabilities, compared to 6% in the very high COI neighborhoods. And for those reporting 3 or more vulnerabilities, the prevalence was quite low, but again, we saw a decline as COI increased. We were also interested in looking at the prevalence of specific combinations of health vulnerabilities. So this table is showing the 5 most commonly reported pairs. The most common combination was tobacco plus substance use, followed by substance use and depressive symptoms, substance use and firearm access and depressive symptoms, and then substance use and condomless intercourse. And when we looked at patterns by COI, we found that most of these pairs declined as neighborhood COI increased, but that the combinations of substance use and firearm access, and then also firearm access and depressive symptoms, which are particularly worrying combinations, were fairly similar across neighborhood COI categories. And these are all small percentages, but this is a large population. So to put this into real terms, this reflects 866 teens who reported both substance use and firearm access, and 722 teens who reported both firearm access and depressive symptoms or suicide risk. Finally, we estimated associations of neighborhood child opportunity index with the odds of reporting 2 or more health vulnerabilities using multivariable mixed effects logistic regression. And we found higher odds of reporting co-occurring health vulnerabilities for teens in lower COI neighborhoods, with an especially large difference comparing the most extreme contrast. So comparing very low to very high, the odds of reporting 2 or more health vulnerabilities was 65% higher. So overall, this analysis showed us that teens living in lower opportunity neighborhoods were more likely to report co-occurring health vulnerabilities compared to teens in higher opportunity neighborhoods. And knowing this relationship may help primary care providers and health systems to offer better tailored community support services and transdiagnostic care for teens with multiple health vulnerabilities. It's important to understand the potential for these different vulnerabilities, which are sometimes considered in isolation of each other in the context of interventions, and that they really do co-occur and can potentially interact with each other. And given recent rises in both household firearm ownership and rates of firearm deaths among teens, better understanding patterns of firearm access and how it co-occurs with other types of vulnerabilities like depressive symptoms and substance use is important. Finally, increasing access to healthcare in low COI neighborhoods could provide benefits for teens who have multiple co-occurring health vulnerabilities. So those are the results I wanted to share. I want to acknowledge our funders, both the PRCCEH Pilot Award for the Extreme Temperatures work, an NIH Career Development Award, and our Possibilities Project funding, which comes from CHOP, and also recognize our amazing TPP team and the patients, families, providers, and support staff within PERC and the Primary Care Network.